So this patient is John E. Wayne. He's a 55-year-old male. His chief complaint is burning chest pain. The patient states that he came into clinic today with a complaint of burning chest pain that has been going on for a while, but recently has become worse after eating a spicy meal. He rates his chest pain a 2 out of 10, but when it worsens, he rates his pain a 5. The episodes typically last a few hours. He has attempted to take aspirin and drink water, but this does not relieve his pain. He said nothing really makes the pain better except for resting and waiting it out. The pain worsens when he eats spicy foods or later at night. Current medications are low pressure, 50 milligrams daily, aspirin as needed. He is up to date on all his immunizations and had his last colonoscopy at 52. He has no known allergies. He has a past medical history of hyperlipidemia, hypertension, and borderline obesity. He denies any surgeries or hospitalizations. His mother died at age 78 of breast cancer. His father passed away from a CVA at age 85. 2 of his brothers have hypertension and 1 has hyperlipidemia. He is a high school graduate and works as a car salesman. He lives at home with his wife. He states he feels safe there. He denies any tobacco usage. However, he drinks 3 to 4 beers a week. He denies fever, chills, fatigue, or a change in energy level. He, however, does endorse gaining 12 pounds that he has lost over the past year. He states he has burning chest pain, discomfort, and palpitations, but denies any radiation, swelling, or edema. He denies any issues with any other body symptoms. The patient does not appear in acute distress, but does appear older than his stated age of 55. His head is normal cephalic without tenderness. His face is symmetrical without signs of trauma. His ears are symmetrical and non-tender. His nose is symmetrical and nares are patent. His tongue is symmetrical and the oral mucosa is pink and moist. His trachea is midline and normal in size. His thyroid is also normal in size. His heart is regular rate and rhythm. No murmurs were heard. His bowels are active in all 4 quadrants. His abdomen is soft and non-tender. His chest expansion is symmetrical and lungs are clear. His range of motion is intact and he is alert and oriented without motor deficits. As far as labs go, his cardiac enzymes are within normal range. His cholesterol tests are within normal limits except for his HDL, which was low at 30. His complete metabolic panel was within range other than his glucose being elevated at 112. His liver enzymes are also within range. He has responded well to the GI cocktail with absence of chest pain. His EKG showed normal sinus rhythm at 74. The differential diagnosis of this patient is gastroesophageal reflux. He has a lot of risk factors and symptoms of this. Symptoms include non-cardiac chest pain, heartburn, and a sour taste in the back of the mouth. Risk factors include older age, an increase in BMI, a sedentary lifestyle, and eating acidic foods. Another one is angina pectoris. This is characterized by substernal chest pain, pressure, discomfort. It usually is brought on by exertion, anxiety, or other stressors. These episodes can last 30 to 60 seconds. We're worried about this because he says these chest pains come in episodes. However, he has no other known risk factors other than his HDL is low. His pain does not radiate. Another diagnosis or potential diagnosis is acute coronary syndrome. This is a group of cardiac conditions that include non-ST elevation myocardial infarctions and ST elevation myocardial infarctions. It can be asymptomatic, but most of the time it's symptomatic. Usually patients complain of radiating chest pain and have an abnormal EKG. His was normal, so this is an unlikely diagnosis. Lastly, we're worried about possibly esophageal cancer. The most common symptom is dysphagia and some chest pain. However, the patient does not state that he has lost serious weight or has any problem swallowing. So the final diagnosis would be gastroesophageal reflux disease. This has many risk factors, including an older age, excessive body mass, smoking, eating habits, and a sedentary lifestyle. It is a condition of the lower esophageal sphincter. The most common cause is when the esophageal sphincter relaxes. These brief seconds of tone inhibit the separation of the swallow. Other risk factors include impaired lower esophageal sphincter pressure, reduced esophageal clearance, and postponed emptying, along with hiatal hernias. So medications for this patient are going to be continue his low pressure 50 milligrams daily for hypertension, omeprazole trial for 8 weeks. Non-pharmacological recommendations are avoid excessive alcohol, avoid spicy foods, eat small frequent meals, education on physical exercise. Diagnostic tests, we're going to review the previous ones, and then if symptoms persist after 8 weeks, we're going to order an upper endoscopy. We can order a urea breath test for H. pylori if symptoms persist after 8 weeks. of the PPI. Patient education, we're going to educate him to stop drinking alcohol, avoid spicy or fatty foods, chocolate, caffeine, take omeprazole 30 minutes before breakfast. The patient will be educated on avoiding spicy foods and large meals, avoid tight or restrictive clothing, eat small frequent meals, avoid eating 4 hours before bedtime like he's been doing, and stress management. Culture considerations. So it is important to ensure each patient is educated on their diagnosis and treatment plan. However, we need to make sure that he is literate, his health literacy matches up with what we are teaching him. Men are actually less likely than women to seek care and have a primary care provider. So it is important to establish trust with this patient. So health promotion, we want to promote diet and exercise, alcohol cessation, stress reduction, and education on the importance of staying up to date on all the immunizations and preventative health. Continue colonoscopies every 10 years. So referrals will be to a dietitian. Follow-ups include 8 weeks to ensure the PPI has worked for the patient for symptom relief. And then at the follow-up visit, the patient should receive his influenza vaccine.